Um, so I'm conscious I'm the last person before morning tea, and I will make sure I keep strictly to time. These are my disclosures, but I have no conflicts of interest in relation to this talk. So over 2 centuries ago, Dr. Edward Jenner created the world's first successful vaccine against smallpox. And this really set in motion a chain of events that eventually led to smallpox eradication in 1979, the first and only human disease to be eradicated to date. And if we fast forward to 2023, we now have access to commercial vaccines for more than 25 different diseases. And we've heard about some more even today. So given these successes, one might wonder why I'm here to discuss vaccine-preventable disease epidemiology. Well, despite the availability of vaccines, many vaccine-preventable diseases continue to cause substantial global burden. And that's fueled by inequities in vaccine access, vaccine hesitancy, and more recently, pandemic-related disruptions to vaccination programs. So in this talk, I'm going to take you on a whirlwind trip of global trends in 8 different vaccine-preventable diseases relevant to travellers, starting with influenza. And I'm mainly going to focus on geographical variations in risk and important risk groups and environments. So as we've already heard, influenza has a global distribution, and there's a seasonal pattern that varies by hemisphere. So cases generally peak in October to March in the Northern Hemisphere and April to September in the Southern Hemisphere, and they can be year-round in the tropics. Influenza is a common diagnosis in travellers with an estimated incidence of between 1 and 3 per 100 travellers per month. And while we observed large numbers of flu cases globally in 2019, laboratory detection of influenza dropped substantially from early 2020 and throughout to 2021 in the setting of pandemic-related public health measures. However, there's been a huge resurgence of influenza globally in 2023 and in Australia, as we've heard. While anyone can get influenza, groups that are at risk for more severe disease include older adults, infants, pregnant women, and the immunocompromised. And while influenza can occur in any environment, one particularly high-risk environment for travellers is that of cruise ships, where there's mixing of passengers from different hemispheres, a cool climate, close quarters, and a higher proportion of older travellers. And in Australia, all people aged 6 months or over are recommended to receive influenza vaccine annually, and this recommendation extends to travellers. Moving on now to measles. So like for influenza, after a huge year in 2019, we saw relatively few cases of measles globally in 2020 and 2021. But measles also appears to be having a resurgence in 2023, particularly in the Southeast Asian region, with the popular travel destinations of India and Indonesia reporting high case numbers this year. The most important risk factor for measles is being under or unvaccinated. And in Australia, those born between 1966 and the mid-1990s are more likely to be at risk of measles, as they may not have received 2 vaccine doses in childhood, and they're unlikely to be immune from natural infection. And shown here is a helpful catch-up guide for measles vaccination, with the key message really being to offer MMR vaccination, assuming people have no vaccine contraindications, to anyone born after 1965 who doesn't have evidence of receiving 2 doses of measles-containing vaccine and/or evidence of immunity by serology. So now rabies. Globally, rabies is estimated to cause about 60,000 deaths per year, and most of those deaths occur in Asia and Africa. Potential rabies exposures are common in travellers, occurring in around 1 per 170 travellers per month of travel to endemic areas. And risk factors for exposure include things like young age, male sex, travel to Asia, and actually being a pet owner. In contrast, rabies deaths are relatively rare in travellers, although a few are reported in most years. And this discrepancy between the number of exposures and rabies deaths can probably be explained by the availability of life-saving post-exposure prophylaxis, or PEP. However, a key component of post-exposure prophylaxis, called rabies immune globulin, or RIG, can be difficult to source in a timely fashion in many countries. And for that reason, pre-exposure vaccination, which removes the need for RIG, should be considered for any traveller to rabies endemic areas. And as we've heard, the schedules are changing, and so a 2-dose pre-exposure rabies vaccination schedule is being recommended soon. So globally, moving on to Mpox. So this has been topical in the past 12 months ago, and formerly known as monkeypox. Mpox has historically been a zoonotic disease seen in Africa. However, in May 2022, countries in Europe began reporting Mpox cases, and health authorities rapidly established that this was the start of a new outbreak. The epidemiology of cases was quite different to that seen previously in Africa, with a lower case fatality rate and cases mainly occurring in men who have sex with men. As of September 2023, we've seen more than 90,000 confirmed cases globally, mainly in Europe and the Americas, as shown in this figure. Although the WHO declared that Mpox was no longer a public health emergency of international concern in May 2023 based on a sustained decline in cases, it's important to point out that cases are still being reported, particularly in the Western Pacific region, especially in China. And in Australia, vaccination is recommended for higher risk groups, such as men who have sex with men and people living with HIV. Moving on now to yellow fever, a mosquito-borne disease endemic in tropical South America and tropical Africa, as shown here. Globally, yellow fever cases fluctuate from year to year, with the last peak year occurring in 2018. Cases in travellers are relatively uncommon, but the risk is estimated to be around 5 per 100,000 unvaccinated travellers per month of travel to South America, and tenfold higher, or 50 per 100,000 for travellers to West Africa. However, between 2016 and 2018, when there were large outbreaks reported in Brazil and Angola, numerous traveller cases were reported, including fatalities in unvaccinated travellers, and a substantially higher incidence rate was reported. Vaccinations recommended for all travellers aged 9 months or older travelling to an area with risk, providing that they have no contraindications, and this is a live vaccine. Moving quickly now to hepatitis A, which is amongst the most common vaccine-preventable infections acquired during travel. The distribution of hepatitis A is presumed to be widespread, with risk highest in areas with inadequate sanitation and limited access to clean water, such as Africa and South Asia. And in a recent analysis of traveller cases reported to the Geosentinel network, the top 3 countries of exposure were Morocco, India, and Pakistan. Cases have occasionally been reported in Australian travellers to high-income countries, such as in Europe, in association with both foodborne outbreaks and outbreaks amongst those whose lifestyle factors put them at increased risk of exposure, such as men who have sex with men. And vaccinations recommended for all adults and children aged 1 or over who travel to endemic areas, and it should also be offered to those with occupational or lifestyle factors that increase their risk of exposure. Moving on now to typhoid, and this slide shows global data on typhoid incidence rates, demonstrating that the highest burden of disease occurs in South Asia. Studies that have examined the incidence of typhoid in travellers indicate that travellers to the Indian subcontinent and to some Pacific islands are at the highest risk for disease, and particular risk groups include visiting friends and relatives travellers, children, and long-stay travellers with prolonged exposure. Vaccination is recommended for people aged 2 years or older who travel to endemic areas. Finally, moving on to poliomyelitis, where global efforts towards eradication have resulted in a more than 99% decrease in wild poliovirus cases globally, and an estimated 2.2 million cases of paralytic polio averted. Currently, wild poliovirus remains endemic in only 2 countries, Pakistan and Afghanistan, and this progress is largely thanks to the large-scale administration of the oral polio vaccine. Unfortunately, the oral polio vaccine has a dark side, and in areas with low levels of population immunity, the live weakened virus included in the oral polio vaccine can genetically revert to a form that can cause paralysis if it's allowed to circulate for a long time, and this virus then becomes known as circulating vaccine-derived poliovirus. Between 2019 and 2020, global vaccine-derived poliovirus cases tripled, likely contributed to by delays and cancellations of polio supplementary immunisation activities due to the COVID pandemic. And although to date there's been no international spread to Australia, international spread to other countries has been documented. So travellers to areas with cases are recommended to receive a polio booster with the inactivated vaccine once every 10 years. So what are my take-home messages? Well, hopefully I've convinced you that vaccine-preventable diseases cause a substantial health burden in travellers. I've shown you that we're observing a resurgence of some vaccine-preventable diseases in 2023. And I've also shown that risks of vaccine-preventable diseases vary based on the specific disease and destination and risk factors of the traveller. It's really important to ensure travellers are up to date with routine vaccines, such as measles vaccine, and also recommended travel vaccines, especially those who are at greater risk due to specific host risk factors or activities. Thank you.